Looks like it's 3 o'clock. Good afternoon, everyone. Thank you for joining us today for this special webinar. Just a quick reminder to please mute your microphones. And if you have any questions, please send them using the chat function. And Dr. Narvey will try to answer at the end of the webinar. Dr. Narvey, if you are ready, please go right ahead.
Okay. Thank you for having me here today. We're going to be talking today about the impact of COVID-19 on maternity clinical practice and breastfeeding support. And where possible, I will try to throw in some anecdotes from local experience, but also we can certainly have a discussion at the end when we get there and see what different centers have been seen during this pandemic, because certainly as I like to say, if you haven't heard of COVID-19, you have likely been on an island somewhere for the last year. But without further ado, we're going to try to accomplish these three objectives. The first is we will review the general impact of COVID-19 crisis on families and healthcare professionals in maternity and neonatal units. We'll look at the current recommendations related to breastfeeding during COVID-19. And the main thrust of this is we're going to really try to see what we as healthcare professionals can do to support lactation and breastfeeding. As we all know, that's critically important. So we'll begin with something that is paramount right now. COVID-19 has severely disrupted maternity clinical practice and breastfeeding support. I work in Winnipeg, and I imagine that the experience here has been very similar to experience elsewhere, where the messages change, the rules change, as I like to say, the goalposts keep moving. Maybe a little less so now, but for a long time, it seemed that every day or every other day you would come into work, there would be a new rule, a new change in how we are to carry out being protective of our institutions and our patients. No doubt, when you have a lot of change, it creates confusion. If I was to ask the group right now to tell me all your local rules and regulations related to COVID-19 and the NICU or COVID-19 in the postpartum ward, some of you who are quite bright would probably have it memorized, but there'd be many of you that would say, I think it says, and when you're not entirely sure of what you're to be doing, that can create fear resulting from the confusion. Additionally, we've also had pressure on healthcare systems. I don't know if anyone is tuning in here from Manitoba, but we've just come out of a near code red lockdown for 2 months. And there's no question it was a lot of stress on the system, a lot of stress for parents who wondered what life would be like when they came into the hospital. What's interesting, though, and this is research that was published in the last year, is that when you look at pre and post-COVID, 85% of mothers prior to COVID expressed an interest in wanting to initiate breastfeeding right after birth. In the COVID pandemic, this number has not gone down. The number's gone up. More women want to breastfeed. Now, it's a small increase, but what I would put to you is that it's not so much the magnitude of the increase that is interesting. It's the fact that the direction of the change. It didn't go down. You could imagine that during this time, with a lot of fear, a lot of uncertainty as to whether or not women could transmit to their infants, which fortunately, it appears that breast milk is not a source of transmission of COVID-19. But you could imagine that while this was unknown, there'd be many mothers that might turn to formula and might suggest that they wanted to avoid that contact altogether. So that is one positive thing that I think we can say has come out of this. And another positive thing is that almost all healthcare providers continue to recommend breastfeeding as the optimal source of nutrition. And that is when you look at the perinatal group. When you look at the NICU group, the numbers are a little lower, but nonetheless, the numbers are certainly still very high. So um, there's no question that COVID-19 has thrown a lot of challenges our way, but one thing it has not done is seemingly impacted the interest and the recognition of the importance of breastfeeding. Having said that, though, there are significant challenges facing um, postpartum wards, NICUs. Um, it says here more than half of perinatal and NICU healthcare professionals report major changes in clinical practices. I would, say that it's almost all. I think that if we're being honest, is there a place in Canada, if not the world? That might be a little grandiose to say that, but certainly in Canada, excuse me, that hasn't been impacted by COVID. Some things that are being dealt with, and this is significant, is earlier discharge. Um, there are many institutions that are being told, because you don't want to have people in the hospital, and I would suspect mothers who have just delivered and their partners would like to get out of hospital as well. As the old expression goes, if you want to get sick, the hospital is the place to come. But with earlier discharge, does that then create problems in terms of lack of educational opportunities and lack of direct contact between those who can provide lactation support and the family? There were long stretches where the partners were not able to come. That created lack of support, stress in the mothers, and when mothers are stressed, that can impact volumes of milk produced. We've talked about the bedside support. What about lactation support? Are there the same number of lactation consultants available when there are restrictions in place? Another issue is on the perinatal side, has to do with separation of mom and baby. Depending on where you are, initially there were recommendations to separate mom and baby if mom had COVID. Fortunately, the Canadian Pediatric Society never took that position here in Canada, and we suggested that mothers and babies should be together. The NICU environment is not really much different, with the exception of if your practice was similar to what existed in Manitoba. If a baby was admitted to the NICU and the mother has COVID, tested positive for COVID, she was not permitted to visit for 14 days. This could, in theory, create a risk for increased infant formula. And the more barriers you put up to getting mothers' pumped milk into the unit, the more likely that would be to occur. Staff shortages have certainly impacted related, and that's on the perinatal and the neonatal side. Especially early in the pandemic, prior to more rapid testing, if you felt ill at all, you were not permitted to come to work. With less staff available, that's less opportunity for hands-on teaching with mothers. And of course, pushing for infants to go home as quickly as possible also leads to lack of opportunity for exposure. One of the things that certainly as healthcare providers we're aware of, and one of the things I think that we should all promote, if not really push for, is support for mothers in the first few days. We know that, as the expression goes, pump early, pump often. If you are not getting the support to get your breast pump, that can have implications. Even though I'm aware that here locally, we encourage early pumping, it's not been uncommon in the last year for me to hear from a mother when I go to talk to her that she still hasn't got her pump, and that's many hours after birth. I'm not faulting our perinatal staff or postpartum staff because related to staff reductions, the resources are stretched thin. But when you look at the analysis of resources that are available, you can see that the three groups that are going to be most active in supporting breastfeeding and pumping in the first few days of life, that being the lactation specialists, the midwives, and the nurses, unfortunately, are the groups that have been most reduced. Um, probably that relates, if I can speculate, that probably relates to obstetricians and neonatologists being deemed to be essential or more essential. I'm sure if the mics were open, we could have some arguments about that, but many hospitals um, have had processes in place that if a physician is required to be at work, there were fast tracking options available to get them back into the workplace, which may not exist for the aforementioned group that is on the slide. What about hospital stay? I've touched on this already, but going into a little bit of detail. Um, Length of stay after vaginal delivery and cesarean section appears to be shorter by about 20%. I did look into some local data yesterday, and perhaps we're doing a good job here in Winnipeg, but our length of stays have apparently not changed here in Winnipeg, whether it's C-section or vaginal birth. The average number of hours for maternity stay after vaginal birth was 29. In this study, it's now down to 23, which represents a 20% drop. And women now are staying, instead of for just under, on average, 3 days stay in the hospital, it's now down to just over 2 days. So again, this presents challenges for the mother or a family that wishes to offer breast milk to their child. Because there's less opportunities for support. And so this is something that needs to be addressed, is how do you pack the same amount of education, or how do you deliver the same support in the hospital and then ensure that after the child goes home, they still have a level of support that will allow mothers to be successful. Another thing that I touched on before is stress. There is no question. You could say this statement for all people. Is there a person in North America that has not experienced some degree of stress with respect to COVID-19? Some of the concerns that mothers have reported in studies are worried that they will not have the support of their partner, who may or may not be able to be there. The fear, as I mentioned, of simply being in hospital and becoming infected. Mothers are also aware that just like their risk of infection, healthcare workers can get infected, and there may be less support for their health, the breastfeeding. There may be less support in the home. Maybe they have a nanny. Maybe they have workers who have been coming to prepare meals or to do cleaning. There's less support in the home. The recommendations regarding breastfeeding and safe birthing, that has also been in a lot of state of flux. We have dealt with that locally, where there have been changes to whether mothers have to mask or not, whether mothers are tested or not. And that has implications. And of course, one of the big things that everyone has experienced is a concern of financial impact. What does this all have? All of these stresses can definitely have impacts on anyone, as I mentioned. But one of the biggest concerns is that whether it's UK, the US, or in Belgium, many people are reporting risk of or feelings of stress, feelings of depression. And again, this can all have an impact on the volume of mother's milk. What about stress from misinformation? We've just come through a period of hearing for 4 years about fake news. And some fake news that we saw locally, and I'll walk you through why it happened, was in mid-2020, when New York was going through a significant epidemic of COVID, as we all were aware. They began to screen all pregnant women presenting to hospital. And they picked up in this one hospital 43 COVID infections. And when they looked at the presentation, roughly a third of the women presenting with COVID-19 proven infection had no symptoms. Now, this shouldn't surprise you. We know that young people are less likely to be symptomatic. So, um, if we know that a third of women presenting in New York were asymptomatic, that got a lot of hospitals scratching their heads about what to do with pregnant women. The decision in Manitoba was to begin offering screening of women in labor. Very shortly after the start of the asymptomatic screening, what was very interesting to see was within 24 hours, the number of women consenting to have a nasopharyngeal swab dropped dramatically. And we can thank for this uh, social media platforms like Facebook, Twitter, various groups in which the word started to spread that they will take your baby away. So if you test positive, you will not get to be with your baby. The reality of the situation was that that was not true. If your baby went to the NICU and you were positive, yes, you would not get to come and see your baby. But if you were to go to the ward, you would definitely get to see your baby. And the reality is that we know from some Canadian national data that only less than 1 in 5 babies are going to the NICU born to mothers with proven COVID infection. So the point of telling you all this is that um, whether this was true or not, you can imagine the stress that this creates for the pregnant women, certainly in Manitoba, is tremendous. And with stress again, what does that do to your ability to breastfeed? Moving on to infection. The fear of infection and increased anxiety are affecting breastfeeding behaviors. So when you look at all of these different countries, you can see that some women decided to change their plans. About 1 in 7 or 1 in 8 women chose to not breastfeed, breastfeed less, or stop breastfeeding or pumping because of coronavirus. In fairness to these women, back in June and October when these studies were being done, there were a lot of questions about babies who could get infected from breastfeeding. We now know that the risk of getting COVID-19 passed on to a baby while breastfeeding is very low. There is 1 or 2 case reports that I'm aware of that seem to indicate a baby may have gotten it from breast milk, but difficult to prove. More likely to get it from contact with skin than the actual breastfeeding. And more on that in a bit. So when we're talking about, and this is really a summary slide, if we want to establish milk supply and we want to maintain breastfeeding, we have to recognize sort of the enemy. What is jeopardizing this opportunity? And just to summarize, because we've touched on it a little bit already, reductions in length of stay have an impact. If there's any barriers to close contact between mother and baby. If this was to become the new normal, there's no question that could have an impact. What about lactation support? Can't stress this enough. You saw on the previous slide that midwives and nurses and lactation consultants all are most affected by the COVID pandemic. And lastly, because I've touched on this a number of times now, let us not underestimate the impact of stress and depression on the ability of mothers to provide milk. And our job is to support them, and our job is to try to reduce these barriers. The other thing that we need to think about is it's not just about the immediate impact, but think about the downstream impact. Breastfeeding has been documented to reduce many things in childhood. And so that can have both an economic and a healthcare burden. So for example, babies that are exclusively breastfed with mother's own milk have reductions in a number of conditions such as otitis media, obesity, diarrhea, sudden infant death syndrome, leukemia, allergic disease, I can add to that as well. It's been estimated that in the United States, exclusive breastfeeding for up to 6 months could reduce the cost of childhood disorders by almost $333 billion. Across Europe, exclusive breastfeeding could save about $8 million in primary care visits, which creates a potential savings of a lot of money. That's about 500 million, if not more, US dollars. And then lastly, due to the benefits of breastfeeding, the prevention of all of the above, in particular the significant conditions mentioned first, you could prevent 823,000 annual deaths in children under 5 and 20,000 annual deaths in women caused by breast cancer. If these aren't reasons to promote breastfeeding and to support these women, I don't know what are. Speaking about the risk of COVID-19 in infants, one of the things that we do know, and this goes across infectious diseases, is that mothers secrete antibodies into their breast milk for a number of infections that babies could be at risk of. COVID-19 has been found to be no different. And in fact, just a few months ago in November, Fox et al. Published a very nice study of 7 women who had confirmed at the time COVID-19 and 8 who were suspected. So these women all wound up having COVID-19. So 15 women had their breast milk tested for IgA-specific antibody to the spike protein on COVID-19. In case you're wondering where you've heard spike protein before, lots of chatter about spike proteins because that's what the vaccinations are all about, is matching the vaccine to the spike protein. So all these women are producing antibody against COVID-19 in their breast milk. So based on that, why wouldn't you want to breastfeed? Formula would contain none of that. Breast milk would contain antibody against the spike protein, and that could potentially offer some protection. So when we talk about supporting healthcare professional or supporting women, where is our real window where we need to get involved? You can see from the slide, the real critical window for success is in that first week. So right after birth, if we don't get in and support the mothers, the likelihood that they are going to come to volume and produce enough volume to sustain that baby through the first 6 months of life is far less than if we did get to them and support them as needed during that time. So what can you do? You can talk about breastfeeding before the birth. You can talk about breastfeeding after birth, asking the question, are you planning on breastfeeding? If not, explore the reasons why not. There are lots of things that we can do, but if we don't ask, we're not going to find out. So a call to action while in hospital. So one of the real pleasures that I have had was being asked to write a series of statements on COVID-19 for the Canadian Pediatric Society. The last one was this is on breastfeeding and COVID-19, was actually just updated. And the update as of January 19th was really just at the end of the statement as a nod to the SOGC, who have advocated for vaccination for mothers who are either pregnant or who are breastfeeding. But these are some of the recommendations that have come out of our statement. And we can certainly discuss some of the thinking behind this in the question period. So mothers being investigated for or found to be positive for COVID-19 infection should not be separated from their infants. I am very proud of this. And the reason I'm proud of this is because when we first released the statement, we released the statement almost simultaneously with the American Academy of Pediatrics. And the American Academy approach was to suggest that mothers and babies should actually be separated, even if they were well. And so we took a different tact with that. We have endorsed that mothers should practice skin-to-skin care and breastfeed while in the hospital, but with some modifications. Like with everyone in the era of COVID-19, we recommend meticulous hand hygiene. We do suggest masking, and you should have hand hygiene before every exposure for routine care, skin-to-skin, and breastfeeding. The thing that we wrote that I know has been controversial, but it is in keeping with other organizations, is that if a mother has recently coughed or sneezed and her chest was exposed and she was not wearing a mask, we have advised to cleanse the breast area with soap and water before feeding as an added precaution. The original document that we published suggested that with every breastfeed, it should be done that way, but we subsequently changed that to really just if you weren't wearing a mask and you coughed or sneezed on an open chest, then we would advocate for that. This should affect very, very few people. Where is the support for having mothers and babies room in together? It comes from, in large part, this study. Again, another study out of New York. The first study that I presented to you was about mothers presenting and being screened. This was a follow-up study that looked at 1,481 deliveries, and 8% of the mothers had tested positive. The important thing that came out of this study was that almost all, so 83% of babies roomed in with their mothers, all were allowed to breastfeed. And by 5 to 7 days of life, about 80% were still breastfeeding. And the PCRs were negative. So the babies, despite rooming in and despite breastfeeding, no infant in this cohort became positive. So what this told us was if you used proper hand hygiene, masking, doing social distancing, limiting visitors, and using adequate precautions, you could safely room in and support the mother-infant dyad. When we talk about supporting as healthcare providers, here are some factors that may affect overall milk production and things that we should think about. So mothers who are first-time moms, older mothers, and I dare to say over 30 is older, but statistically that's where there could be some more challenges. The obese or those with diabetes, those with prior breast surgery or ovarian cysts or multiple cysts as in PCOS. Those born by cesarean section or have had hemorrhages. Excuse me. And those who have had a preterm birth, or those who are undergoing a great deal of stress, which could be induced from mother-infant separation. Any of these things may delay the first expression or the first breastfeed, and this is what could lead to this statistic on the bottom, that 60% of mothers with delayed secretory activation are more likely to stop at 4 weeks with breastfeeding. So if we target these women as being really the ones in need of our attention, we may be able to improve as healthcare providers the ability of these women to successfully breastfeed past the discharge time. So upon discharge, I would encourage you to talk about the importance of regular and frequent breastfeeding at home in order to build up that supply. If direct breastfeeding is not effective or not possible during these early days, a hospital-grade double electric breast pump to get proper initiation and maintain good volume is recommended. Education about how to properly use it would really be an asset to give these mothers before they go home. Talking about strategies to continue breastfeeding, offering the mothers further counseling, and especially providing them with available resources at home during a time when they may be limited in support in the home is really important. If we send these mothers out without adequate support and ensure that they have follow-up, many could be doomed for failure. So let's anticipate and try to get adequate resources for after discharge. Lastly, I just wanted to add something that is significant and is a potential barrier is if I'm given early discharge, if a mother has a baby in the NICU and she wishes to pump and mom has COVID-19 again, she wouldn't be able to come into the NICU. How do you get the milk from the home to the NICU? I'm showing you here, and I won't read out the entire thing. I could certainly send this around if people are interested in seeing how we do it, but we created a protocol for mothers who are expressing breast milk to safely get it to the hospital. A lot of it has to do with cleaning at multiple stages and ensuring that the milk that is coming in has been adequately taken care of so that we are not bringing infection into the hospital. There are studies out there that have shown that if you freeze, whether it's 4 degrees or minus 20, you freeze milk, COVID can still remain active upon thawing. So it's very important that all milk is handled appropriately. It's all cleaned appropriately, at least the containers are, before you bring it into the NICU. And again, happy to share this if anyone wants our protocol. And with that, these are the references, if not listed elsewhere. And I would invite any questions and thank you for your time.
Thank you, Dr. Narvey. If you have any question, please unmute yourself and just go ahead and ask. No questions, apparently.
Was I that clear?
I think it was.
There's a question from Helen wondering if this is going to be made available on the YouTube channel.
Yes, it will be.
Excellent, thank you.
Oh, maybe I'll have a question for you.
Sure.
So since the studies have confirmed, more than one study has confirmed that there is antibodies, specific antibodies in mother's breast milk. Why are healthcare professionals recommending masking for the mothers who are breastfeeding with the baby, knowing that it is important for the baby to see his mother's face?
Well, that's a good question. You know, and I think that speaks to, I think that speaks simply to the risk of the aerosolized droplets. You know, when you're talking or if you sneeze or you cough, you could have a baby that, like we know, Morad, that most babies, you know, almost all babies are born, even if mother is COVID positive, most babies are born without COVID. They're not infected at birth most of the time. We do know when we look at the literature that the mothers who are the sickest are most likely to transmit COVID to their unborn child, so that there have been some fetal infections that have been detected very shortly after birth. And those mothers, what they had in common was they were extremely ill, often in a medical intensive care unit. However, the mothers who are COVID positive or don't know they're COVID, what if you work in a hospital where there is no screening? It's safest. It is safest just to keep the mask on, so that although you're not likely to give it through breast milk, you don't transmit it to your infant with your mask off. But I agree with you. I do hear your point about not seeing the mother's face. That is a challenge. I mean, one thing I suppose that I can offer is I keep seeing people wearing face shields that are clear, you know, or even masks that are clear. You know, that might be something that people can look at purchasing if that was a concern.
Yeah. Thank you. Any other question from the audience?
Yeah, I did see in the chat there was a question about commenting on, I think it's probably the Danish paper. that found less preterm birth.
Yeah.
I think that correct. There are many centers around the world that have reported smaller numbers of preterm infants, in particular infants under 29 weeks. I can only share with you our local experience that in the first 6 months of the COVID pandemic, our numbers really dropped. I know that there are some people online right now who work here with me in Winnipeg, and they would know that, you know, we were walking around our unit saying, where are the 24 weekers? Where are the 25 weekers? What I can tell you is the difference by year's end was a difference of one birth from, at least here in Winnipeg. There was one less preterm infant born actually in 2020 than there was in 2019. So that would seem to indicate that there may have been, depending on when you look, which window you look at, there may have been shifts in birthing patterns. Or it could be that there is a difference, but just here in Winnipeg, we didn't see it.
Yeah. So there's another question. You mentioned directing mothers to breastfeeding support following discharge. However, there are a lot of challenges for those providing these supports to people in home or in clinic, such as no in-person visits through telephone consults, etc. Do you have any thoughts or information on accessibility challenges to these post-discharge resources?
That's a great question. So anything I will say is purely speculative as to, you know, what might work. I am aware that there are challenges galore. You know, strangely enough, the restrictions have gotten, seems tighter as time goes on, but people were behaving a little more strict in the beginning of the pandemic. So it's just, I find that's interesting that now people are more willing or more interested in going out and helping and being part of, you know, everyday life again and getting back to a sense of normalcy. But the pattern initially was the opposite when our counts were lower. But as far as how to do this, I think we all have to get creative. I think that the use of videos, YouTube channels, the use of Zoom, or I don't need to provide a specific channel, it could be, or Teams or any other video platform. I think we just all have to get creative. If you look at family doctors, access to them, there's many virtual visits now. I think everything needs to be virtual, or a lot has to be virtual. The one thing I guess I would say about the virtual visit is, and I'll confess, you know, I'm not a lactation consultant. I've never, you know, I've never given a woman specific advice about the positioning and so forth and using nipple shields. That's not been my part of my career path. But I do imagine there probably is, there are some limits or limitations to what may be done over video. But as best you can, I think that's the strategy we all have to do for now.
Thank you. Any other questions from the audience? Okay, well, with that, thank you so much, Dr. Narvey. Thank you for the audience for taking the time to join us today. As we mentioned earlier, we will be posting this webinar on our YouTube channel just for future reference, or if you want to share it with your colleagues. So thanks again for joining us, and have a great day.
All right, thank you.
Thank you, Dr. Narvey.
Okay, take care.
Bye.
Bye.